Good evening, everyone. How are you doing? Still alive? Thumbs up? Okay, good. I know you've heard this quite a few times today, but delegate attendees, please do not forget to complete those feedback forms. It's so important as it really helps us to improve and innovate and really help build connections for you now and then for the next assembly. I'm really happy to announce that we are still on track for completing our mission of executing meetings through day one, and as long as we execute efficiently tomorrow, we will be able to make a donation to the charity of someone in this room's choice. Who thinks they're going to win? Woo, okay, that's pretty good. As you finish eating, I'm really delighted to introduce you all to tonight's superstar here at the Whitley. He is the Executive Vice President and Chief Innovation Officer at the Joint Commission, Jim Merlino. Please join me in welcoming Jim.
Thank you, Hannah, and good evening, everyone. Thank you for having me. A couple things I want to say at the beginning. First, no access to the schedule of surveys. Zero. It's like only one person has that. They live in a cave. Secondly, I want to thank the Millennium Alliance. You know, it's interesting because I spoke to one of their conferences when they first started, and there were like 5 people at a table, and that was it. And now you look at it today, and I recently had the opportunity to see the list of people here in attendance. It's really amazing. And I came later when it was larger, when I was still at Cleveland Clinic, and was able to network with a lot of the companies here, and we actually built relationships based on that. So congratulations to the team that puts this on, and for all of you for coming. The third thing is, I do realize that I am the only thing standing between dinner and the bar, so I cut my slides in half, just so you know. You're welcome. The things I want to talk about tonight briefly are, I want to keep it a little lighter because you guys had a long day, and it's a great conference, and I want to leave you with some things that tie us back to why we are here and what we do every single day. It's kind of the lessons that people teach us, what's important to people, a little bit about digital transformation, because this is clearly on everybody's mind, and we're seeing a lot of this going on in the industry, obviously. And then I do want to talk a little bit about what we're doing at the Joint Commission, because, you know, it is like an advertising commercial, so I have to talk about it. So I am a colorectal surgeon, and how a colorectal surgeon or a proctologist stands up here on stage during dinner and talks about the patient experience is a great story. You can catch me at the bar. I might be able to share after a few cocktails. But I was early in my career, and I was helping to take care of the person on the right, and I had just left the hospital. It was late at night, and I went home and went to bed, and my phone starts ringing. It's literally like 2 o'clock in the morning. And it's one of my partners calling to tell me that the patient that I was helping to take care of had arrested and died in the hospital. And it was very surreal for me. So I drive in the hospital, and it was memorable for a lot of reasons. And I get to the hospital, and for those of you that know the circumstances, you get up to the floor. It's like, you know, the nurses who are the Navy SEALs, they're the first ones to storm the beaches in any hospital emergency, are taking care of the body. They're cleaning up the crash cart. They're trying to help the family. Somebody from mortuary services who, you know, was at home in bed, got called in to ask the family in the middle of the night, what do you want to do with the body? When 8 hours earlier, the family had been told, go home, don't worry, everything's fine. So it's really surreal, but for me, it really launched my understanding and my career in the patient experience, because that person that died in the hospital was my father. I know, right? It's a long time ago, I'm over it, but the point is that my father was in the hospital for an ambulatory procedure because he was supposed to go home the same day, and he suffered a serious safety event, which was a preventable error, and he ended up staying 8 days and succumbed to another event and ultimately died. And it really taught me that, you know, we have epiphanies in healthcare, and we shouldn't have to have epiphanies to recognize that it's different on the other side. I've been very lucky, because I'd never been a patient, and my family had never been, no one in my family had been seriously ill. But it really teaches you that, you know, what it's like to be a patient and walk in the shoes that patients go through. And for those of you that have been there, you know. But for those of you that haven't, it's different. Jump ahead 10 years later, my father-in-law, unfortunately for the record, my wife looks nothing like him, calls my wife, who's also, and this story is told with permission, he's still alive, Um, he calls my wife, who's also a physician, and says, I'm having blood in my urine. And this is nearly 10 years to the week that my father died 3 days before Christmas. And my father had bladder cancer, same symptoms. So he drives to Cleveland. We get him a same-day appointment the next day, and he sees a urologist. And the urologist tells him, well, it's probably cancer. Fortunately, it wasn't in his bladder, but it was in his kidney. I don't know if that's fortunate or not. He says, it's probably cancer. You've had a big surgery 20 years earlier, so you're going to need a big surgery again. You're probably going to be in the hospital for 2 weeks, and we should do it right away. So my wife is with him, and they leave the doctor's office, and she brings him back to our house. And on the way back, she calls me and says, what do you think? And I say, I think we need a second opinion. And 2 days later, they get a second opinion. My wife is there. And the different urologist at the same hospital says to my father-in-law and my wife, it's probably not cancer. If we need to take it out, I can do it laparoscopically. You'll be in the hospital 2 days, and we'll just watch it and see what happens. So jump ahead 6 months, we watch it, it gets a little bigger. They take it out laparoscopically, he's in the hospital 3 days. It's not cancer. And what's fascinating about it is that those are two urologists that were practicing at the same organization down the hall from each other. So if you think about being on the side of a patient as a family member or a patient from the standpoint of the experience and preventing safety errors, and if you think about what people go through every single day with the variability of care that they have when they have conversations with caregivers, the problems that we face in healthcare are enormous. When I became the chief experience officer at Cleveland Clinic, a week after I moved into my office, Toby Cosgrove, who was our CEO at the time, came in and he gave me a letter and he gave me this picture. And the letter was 5 pages. And I read the letter and it started off by saying, the Cleveland Clinic killed my wife. And I'm thinking, oh my God, because my perspective is I'm a physician. It had to be a medical error. We missed something. Holy crap. I read through it. He goes on to describe her journey. She had breast cancer. It was diagnosed by routine mammography. It was treated. She was cured. She had surveillance. Several years later, she had a recurrence. It was caught on surveillance. It was treated again. It advanced to stage 4. It was no longer able to be cured. It was under maintenance therapy. Eventually, she landed in hospice. And she's at hospice, and she's at home, and she's not feeling well, and they take her to the emergency department, and the emergency department admits her to the hospital. She's on hospice. And she's in the hospital for 5 days, and she dies. And the end of the letter says that you failed my wife and my family because the only thing that she wanted, more than anything, was to die at home with her family and her dogs. And if you look through the medical record, they told everybody they just want to go home. The nurses, the care manager, the social workers. You could read the medical record, I did. But none of us could make it work to get them out of the hospital for an admission that they should not have been admitted to begin with. So what's the moral of the story? The moral of the story is that what we do, whether you're directly involved in healthcare or whether you're an organization helping to support healthcare, all of us in this room are in an industry that's really hard. And I'm very good at stating obvious things. Just ask my wife. This is a picture that went viral in the New York Times with a young daughter who was helping her sister get through cancer. And if you think about the human condition that we go through every single day, it's enormous. And no talk is complete these days without this. Exactly. And here's another example. So we talked about the patient, right? Now we talk about the caregiver. This is Lauren Leander. Anybody here from Banner? She was a Banner ICU nurse during the pandemic, came out of her shift, encountered a protester, stood up to the protester. It was captured for the world to see. This was in the New York Times. It went viral. And Lauren left nursing because of the stress and the burnout, like so many other nurses coming out of the pandemic. So if you think about the human toll and the things that we do in healthcare, it's enormous. And I would leave you with this as my last topic on kind of what people tell us, is that, we're all in this together, right? At the end of the day, we're all in this ecosystem called healthcare, and we're not in this ecosystem because we work in it, right? You're operators and nurses and other leaders in organizations, you're CEOs and salespeople selling products to support healthcare. I mean, we're in that ecosystem, but we're in this ecosystem because what I just described impacts all of you and me and all of us together. So the things that we do every single day for the people that we serve and the organizations we work with are not just about them, it's about us and our families. So think about that. What's important to people? When I first became Chief Experience Officer, I had no idea what I was doing. Like you don't go to school to be the Chief Experience Officer. It's like, hey, you did a nice job, we like you, take this role. Like, okay, great. So I am still full-time practicing colorectal surgery. I walk into a patient's room, and I had a woman who was 35 years old at the time, kind of a tragic story. She had recurrent rectal cancer, and I'd been treating her for a long time, and she was back in for another surgery, and I said, listen, I'd like you to do me a favor. I'd like you to take this notebook, and I want you to record what happens to you in the hospital. And she said, fine. She's like a willing participant, great experiment, nothing else to do, hanging out. So at the end of the stay, I walked in after 5 days of uncomplicated hospital stay from surgery. And I said, how'd it go? Did you capture your experiences? And she goes, yeah, I captured my experiences, but more importantly, I wrote the names down of everybody that took care of me. But I missed 3 people. I go, oh, that's interesting, but tell me about your experiences. She goes, no, let me tell you about the people. And I go, okay, so she starts telling me about the people that she encountered in the hospital. And what was striking to me is how many people took care of her. So at the end of 5 days, how many doctors do you think took care of her? It was 8. So that was me, my fellow, my resident, the anesthesiologist, a couple other people, the oncologist. 8 doctors seeing her over 5 days. How many nurses? 15. So this is kind of interesting because she captured the names of every single nurse that took care of her, from the time she came into the hospital to the time she left. And it's not like there was a contest where there's a sign outside the door saying, hey, come in, meet the patient so she can get your name. These are people that actually took care of her. 60 nurses. 60 nurses. And at the end of 5 days, there were so many people that took care of her, from the nurses to the doctors to the therapists to the people that helped clean the room to the people that fed her food. She captured the names of all of them except 3. That it really makes you realize that if you're going to work on improving the experience, right, it's a cultural issue because you need to get people aligned, right? It's not one person's responsibility. It's like, oh, it's the nurse's responsibility, they'll take care of it. No, it's everybody's responsibility. And if you consider what we do every single day, whether it's in the hospital or in the clinics, what is it? It's deliver safe, high-quality care in an environment where people feel cared for. So we did a study when I was at Cleveland Clinic to really understand what was important to patients. And as you can imagine, patients have tons of emotions, right? If you've been a patient, you know. It's stressful, right? Nobody is a patient and thinks, oh, this is really easy. I wish I could do it more often. There's certainly anxiety. There's fear and terror. My primary practice was cancer surgery, and I assure you, when you tell a patient that they have cancer, there's only one thing they think about. Do you know what that question is? Exactly. Am I going to die? That's all they think about. Everything else is irrelevant. Everything else gets drowned out. That's fear. There's uncertainty and there's confusion. We make that worse, by the way, because we don't communicate or coordinate. But that's what patients feel. But this was the most interesting thing. So what do patients want? right? So we think, oh, they want to be in an environment where people are happy, they want to be satisfied, right? You hear that a lot. No, they don't care about that. They want respect. And it's interesting because they don't want respect like, oh, Jim Merlino, I know you, right? I respect you, Mr. Merlino, Dr. Merlino, whatever. They don't want that. They see respect as, do we know who they are? Do we know something about them? Do we care enough to learn something about them? And that's really important to patients because they believe that if we care about them and we know something about them, that we will care better, we'll take better care of them. So it's not about just knowing their name, it's about knowing something about them. It's about being connected to them. And what's interesting is that, patients didn't read the book about being emotionally detached so you could be objective, right? They don't want that. They want connection with you. And they want communication. And we all know that because there's 9 questions on the government HCAP survey about communication, so it must be important. But what's fascinating is when you focus group patients, it's important that the nurses and the doctors communicate with them and their families. But what's more important is that the doctors and the nurses communicate with each other. Because patients are relatively unsophisticated in healthcare. I said that once in a group of patient advocates. I had a duck from the knives. But what's interesting is that patients don't evaluate their providers based on medical knowledge. They evaluate their providers based on what they think is important. So if I walk into a room at 6:30 in the morning, wake the patient up, do my 3-second exam, and leave, and the nurse walks in two hours later and says, what did Dr. Merlino say? And the nurse doesn't know, the patient thinks that's probably bad. And for those of you that are on the provider side, that's actually really bad because we lose coordination and bad things happen. And patients want happy people. It's funny because we hired a company to do this survey or this work for us. And I remember the readout. I was with our chief nursing officer, and the surveyor people were telling us that patients want happy people. And the CNO, my colleague, leans over and goes, did we just pay like $75,000 to have a company tell us that patients want happy people? And I'm trying not to break my smile, and I say, yeah, I think we did. But patients actually don't want happy people. When you focus group it and you ask them, what they want is consistency. If I walk into a room and I appear stressed or rushed, the patient will not engage. And they wonder, did they do something to make me stressed? If a nurse walks into a patient's room and is rushed or is trying to do things quickly, the patient will not engage because they don't want to hold the nurse up. There's tremendous deference to healthcare workers. It's a power differential, right? People put doctors on a pedestal. They put nurses on a pedestal. They don't want to cause them more anxiety. They're always concerned about us. So they watch everything we do. They watch everything we say. I should say they listen to everything we say. So that engagement of how we interact with patients, how we project, and how we work with each other is really critical. And finally, they want empathy, and it's true. If I gave each one of you a survey and said, true or false, do patients want providers who are empathetic? You'd say, of course they do. But they don't actually tell us that. What patients tell us in surveys is they say, I wish Dr. Merlino understood what it's like to be me, right? I wish that the nurse understood what it's like to be me in this bed or me in this clinic. So that's what people want. They want connectivity because they think we will care more. They want us to communicate better because they believe that when I don't know what the nurses are doing and vice versa, that's probably not good. And it's true, it's not good. And they want people to be consistent, and they want people to understand that we've walked in their shoes. And it's funny because when I was doing a lot of work in patient experience a long time ago, people would say, what's the one thing that I can do to improve the experience? And I would say, spend time understanding what it's like to be a patient, because you'll know instantly what you need to do, because it's different. So digital transformation is fascinating. It's something that we're paying a lot of attention to at the Joint Commission. We get a lot of incoming around, what's the Joint Commission's position on digital? What's the Joint Commission's position on AI, et cetera, et cetera? And you all know better than I do, and there's many companies in this room that are playing in this space. But healthcare is in tremendous transition right now for a lot of reasons, but particularly because of digital. When you think about virtual health, interoperability, I'm not going to read the numbers, you can see them, how health outcomes are impacted, and of course, cybersecurity is enormous, right, and growing. I just saw today, I'm sure many of you did, that somebody hacked the federal court system, probably the Russians. But the challenges are enormous, but the opportunities are amazing. And if you think about the standpoint of industrial revolution, and this is kind of a cliche, but where are we in healthcare? I mean, we are blurring the lines between the physical and the digital connectivity of how we're delivering care, right? We're at the precipice of changing the way that we deliver. And I would submit to you that how we accept that transformation is going to be critical. My wife is the Chief Medical Informatics Officer for the Cleveland Clinic Enterprise. And she has a team that helps doctors work with the medical record. And it's very generational. So earlier practice doctors coming in are very attuned to using digital tools to practice. The more experienced doctors, people my age, still use the abacus to add, but they still have a challenge with it. And one of the biggest challenges that she finds, and this is true not just at her location, which is Cleveland Clinic, but others, is that we take technology and we add it to really bad process. Like, if you want to see 100 ways that doctors practice, if you've seen 100 doctors practice one way, you've seen 100 different ways of practicing. Because there's no consistency in workflows, there's no re-engineering of how we do things. And what is the absolute myth is that the practice of medicine is an art. It's not. It is something that can be improved, it's something that can be taught, it's something that can be monitored, it's something that can be coached. And we are consistently taking bad processes and marrying it with new technology, which just creates chaos. We have to think about re-engineering how we deliver care. That's the answer to the future to be successful. And imagine this, like AI. So one of the biggest questions that my current organization gets incoming from is, what's the guidance that the Joint Commission is going to provide on AI? Now, if you are Northwell Health, you have an AI person. You probably have an AI team, right? Northwell, Mayo, Cleveland Clinic, Common Spirit. If you're there, congratulations. You all have tremendous resources focused on this. But if you're X hospital in Louisiana or B hospital in Mississippi, you don't have the resources. And most hospitals are like that. So the question is, how do we provide information that doesn't stifle innovation? Because that's really critical, right? We don't want to do something that stifles innovation because the promise of AI is enormous. But how do we provide information that helps organizations think about the guardrails to keep patients safe and to keep their organization safe? That's the challenge. Because I would ask this question for you. What is AI going to be like for healthcare in 5 years? Does anybody have a guess? We don't know? What's it going to be like in 10 years? Like, what is AI going to do for us in 5 to 10 years just in healthcare? I would submit to you that we can't imagine the impact. Because if you look at right now, the most widely employed application of AI is for things like transcription, right? For medical decision making. And that has come on at an enormous pace over the last 4 years. 4 years ago, people really were not talking about AI. Today, everybody's talking about it. Imagine that we don't know what AI is going to do in 5 years. We can't imagine that. If you grew up when I did, my cell phone was the size of like a brick, right? You could barely hear on it. It's like, It took 3 minutes to connect. My call-in internet connection took 10 minutes to connect. And I could maybe get the news, which was like lines. But think today, you carry in the palm of your hand a computer which is 10,000 times more powerful than the computer you had on your desk 30 years ago. Who could have predicted that, except, of course, the people that would watch Star Wars and Star Trek reruns every day. But I would submit to you from a technology standpoint is to lean in to think about how technology can be beneficial to what you do every single day to take care of the people you serve. Don't do things that are going to limit your imagination to innovate, but think about the risks of what you need to think, to do, to protect yourselves and your patients, because the opportunity is enormous. All right, new Joint Commission. So I've been with the organization for 2 years. I joined because of this guy, John Perlin's our CEO. This is my commercial, right? I have to be able to say something about the Joint Commission. I will tell you that the Joint Commission is an interesting organization. It's 70 years old. Who knew? It was founded by the 5 major medical organizations 70 years ago. The American Medical Association, the American Hospital Association, the American College of Physicians, the American College of Surgeons, and who knew why but the American Dental Association. It's like the odd man out. But hey, it's good. Their sole purpose was to elevate safety and quality for patients and to bring standards. It lost a little bit of its way, and it got overly burdened. We've replaced the entire team. I call it pre-Perlin, post-Perlin. He hates when I say that. But John's been the CEO now for just over 3 years. I've been there for 2 years. And we've done some things that are really, I think, reducing burden for organizations. We've cut standards in half, nearly in half, from 12. You're welcome. I did that. No. Just kidding. We've cut standards. We've reduced the COP requirements, keeping in mind that we have a responsibility to the federal government and CMS, who is an amazing partner. And we've really trimmed down what is known as the above and beyond. It's kind of interesting. For the last couple of decades, the leaders of the Joint Commission would just add something and say, oh, hospitals should be required to do this. And we're like, having been a customer of the Joint Commission for 20 years, I'm like, are you nuts? Like, what is that for? Like, every state in the union bans smoking in hospitals by law. Why do you need a standard on that? We got rid of it. So burden reduction is number one, right? Because we came from where you sit, and we are like you. We're a nonprofit. We're people that have led in healthcare, and we want to be a better partner. We focus on things that matter, right? So if you think back to my father's story, who essentially died of a serious safety event. We didn't call it that 25 years ago, but that's what it was. It's a preventable serious safety event. It's the 3rd leading cause of death in the United States today, after not including COVID. There are 3.2 million people in the United States that will suffer a serious safety event that's preventable, and 440,000 people will die from one. Think about that. There's 5,000 hospitals in the United States. 440,000 people will die of a preventable error. Now, I was speaking to a board a long time ago before I came to the Joint Commission, one of my clinic boards, and a physician on the board goes, that's not true. That number's wrong. I'm like, all right, what would you like it to be? You're obviously going to say it's not higher. Let's call it 220. And I said, let's call it 110. I said, how about 50,000? So 50,000 divided by 5,000 is, right, 10 people die at every hospital in the United States from a medical error. That's unacceptable. It should not be acceptable. Now, doctors and nurses don't walk into the hospital thinking, I'm going to kill somebody today, right? That doesn't happen. It happens by accident. We feel bad about it. But it happens, and we have to figure out ways to prevent it. So we are paying attention to the things that we know cause errors, and the things that we know you're already paying attention to, things like pediatric radiation doses. So the federal government does not require hospitals to measure the dose of radiation going to kids on routine x-rays. We do. Why is that? Because the American Radiology Society says it's important. Because there's no study that says if you over-radiate children, they get cancer. We've never studied that, right? This group's going to get radiation, this group's not going to get radiation. Oh, look, this group gets cancer. That's not been studied. It's never going to be studied. But we know it's a bad thing, and there are several incidents in the United States that have caused that to be a problem. Radiation safety, MRI safety is another one. So last week, 2 weeks ago, it was reported that a metal object flew through an MRI machine. Did anybody read that story? So the MRI safety rules are not required by the federal government. We implemented those with input from the industry. So the fact that you need to keep an MRI unit sterile, meaning no metal, is because of the Joint Commission. That's important. Having come from an organization where I've been involved in a root cause because of an oxygen tank shooting through an MRI machine, fortunately didn't kill anybody, it's a big deal. It's very serious. So anyway, the moral of the story is we're focusing on what counts, which everyone looks at this and says, yeah, that stuff counts. Surgical timeout, right side procedures, hand washing, workplace violence. These are the things that are relevant issues for healthcare always. We are innovating our products. So if you've been through a Joint Commission report out, you've seen the SAFER matrix, right? Has anybody seen that at the report out? Exactly. So this is what you get, if you haven't seen it, at the end of your Joint Commission survey, where the surveyors show the CEO and the executive leadership team like all these numbers. In my last survey before I joined John at the Joint Commission, I was in an auditorium. My CEO is sitting by my right, and our board chair is on the left, and they flash up this SAFER matrix, and it's got all these numbers on it with all these colors. And Tom leans over, he's Croatian, and he goes, what does all those numbers mean? And I go, I have no idea. I don't have a decoder ring. So literally, as soon as he does that, my board chair, Beth, leans over and goes, what do those numbers mean? I'm like, I don't know. So we've made them all words now as opposed to numbers. So instead of saying you had a finding at FZC 578-4729356, we say patient falls, right? We're doing benchmarking. Here's a good one for you. The Joint Commission has collected performance data on accreditation for 30 years for 90% of the hospitals in the United States. 30 years, 90%. And you know what that data, where that data was? It was in a bunch of databases. Exactly, that's what I said. So last year we bounced it into the cloud. We built a benchmarking tool. So if you are a Joint Commission customer, by the way, thank you for being our customer. When have you heard that? If you are one of our organizations, you can use this tool today, because we rolled it out in January, to go in there and look at your hospital performance for accreditation with COPs and non-COPs against every hospital in your system, right? And you can look at every hospital in the United States that benchmarks against your hospital to see how you do. Of course, the other hospitals are blinded. Why is that important? Well, number one, because instead of like spending the last 6 months before your survey preparing, like you can say, no, this is where I know my weaknesses are, that's where I'm gonna put my energy, right? So it's highly valuable information. And we've taken this to the government and said, look at these standards. These are the things that we should be thinking about revising. These are the things we should double down on because they're important. And finally, we're moving to a continuous model. It's like, how do we do continuous readiness as opposed to like every 3 years you come in and say, hey, let's do the survey, we're here, right? So this is information, by the way, that's come from the industry. It's come from the new leaders at the organization. It's like, you finally get your hand in the cookie jar. It's like, yeah, we're going to change things. So we're listening, we're evolving, we're innovating. So and finally, and I'm keeping track, like, we're almost to the bar. My final word is that remember why we're here, right? It's for the people we serve, which is our patients, because being sick sucks, and no one wants to come to healthcare. And it's for people like this young nurse who left healthcare because of the stress and the burnout of the industry. These are the people we serve. And those people look a lot like us because we are all in the same boat. So why should we care? It's the right thing to do. I mean, I'm not going to read the list. You can read the list. But how we think about working together to improve the experience, which is to elevate safety, pay attention to quality, make it seem like we care for people and their families, is really why we're all here. So with that, thank you very much. Enjoy dinner and enjoy the rest of the conference. I think she's going to ask questions, but
Do you want to do a Q&A or no?
it's up to them.
Who wants to ask questions? Okay,
Oh, there's a question.
we'll have some.
Thank you for your talk. I really appreciate it. And I will find you at the bar because
What's that?
I will find you at the bar because I have a question for you related to one of your stories. But for all of us here, the benchmarking data, when and where do you see that being available to members of health plans, patients? Because patients are not always super sophisticated in their care,
No.
right? But every once in a while you get a patient advocate that can help people shop for their care, right? And find those different opinions, understand the scary things that you talked about,
Right.
and understand the strengths and find out where they are and if they have a shot to get that level of care. There's been a lot of debate around that in various groups for years. Where do you see that heading in terms of transparency for everyone about hospitals and physicians individually are performing?
Yeah, well, I was just going to say, you're really talking about transparency overall. I think, personally, I think transparency is one of the most powerful tools we have to improve. And I don't think organizations should be afraid of it. When I was at the clinic, one of the things that we did to improve physician communication scores was to release physician communication scores. And they were public. We released them. Toby was a big believer in patient experience. We released them. It was controversial. I wasn't driving to the clinic for several weeks in hiding, but with security. But it improved the scores because nobody wants to be last on the list, right? And when you get done talking about ways to improve, you finally say, just give them the data and it'll take care of itself. Which, by the way, we do for other things, right? We do it for quality data. We do it for safety data. In my department in surgery, we did it for as long as I can remember. So personally, I think it's very, very important. On the data that we have, if you're an organization that we serve, you have access to it today. The issue with transparency for that data is it's required by law that it's protected. So there is conversations in Congress. Senator Grassley actually recently introduced a bill that would make some hospital survey reports public. That's been a topic of debate for a long time. Our position is we're kind of agnostic because we're here to serve. I understand both sides of it. I mean, if it's information that can be potentially hurtful to patients, we certainly don't want that released, right? On the other hand, if we think it can help improve and raise all ships, there's an argument to be made for that. But I do think that transparency is important. I will tell you that if you look at every initiative over the last 30 years to improve safety and quality in the United States, the single initiative that has improved safety and quality is Medicare's conditions of participation. Medicare's value-based purchasing program, when they made public reporting of data tied to reimbursement. That singly improved quality across the United States. Now, we can argue all day about those metrics and whether they're good or bad. Some are good, some are bad, but that's what it did. So it tied it to money, and it made it public. Sure. Any other questions?
Yeah, same corner, popular corner. Thank you for the talk.
Sure.
You made it very personal, which I think we all appreciate. I'm a general surgeon. You gave me flashbacks
Yes.
to anastomotic leaks, so no thank you for that. More of I want to plant a seed in your head. So I was the chief of surgery at the VA, and I got a call one day, co-surgeon cut the common bile duct. You can probably appreciate how.
I've never done that.
Yeah,
for
it's
the record.
a horrible experience. Cut the ureter.
Even double worse.
Yeah. It's a horrible experience. He had the wherewithal and the courage and the strength to call for help. I was there. I came in. I said, you know what? Tapped him on the shoulder. You're out. It's my case now.
Yeah.
And the reason being was it's very akin to like what happens when.
Wait, was it a gynecologist? Don't tell my wife I said
No,
that. My wife's one, I can say that.
It's very akin to what we do with police officers when they're involved in a shooting. What do? You take them out of duty. It doesn't matter whether they're at fault or whatnot. There's a lot of emotion, there's stress or anxiety. So that's what I did for this guy. And I said, I'm going to make the decisions. You're still in the room, you're still participating, you're still going to be part of the care, but I'm taking ownership so that you don't have that burden. And I talked to the VA surgical quality, I can't remember his name, it was out of Michigan. And we talked about this idea of being able to, basically oversee and remove somebody from the care, but put them on the side.
Yeah.
I'm not aware, we did this locally, we were able to do it locally. But agreed it was a good decision for the VISN that we were in the Mountain West. Not aware of any national program or entity, but anyway, I'd like to just plant the seed to say, I think it's a really good idea because it keeps the person there, it incentivizes them to call for help. I mean, as surgeons, there's so much ego involved, and once you have that tragedy, the emotion takes over, and you are not making good decisions.
Yeah, I agree with you. First of all, thank you for your service to the VA. I practice at the VA, and I think the VA gets a lot of bad press when they really deliver great care. And I don't think we recognize what the VA delivers to patients. John was actually was the deputy undersecretary of the VA. He ran the hospitals late under Bush and early under Obama, and helped to lead a team that brought a lot of transformation, and the care is amazing. Secondly, I can relate. I had an experience early in my career where I had a 34-year-old guy. I mean, it's emblazoned in my head. He had 3 really young, beautiful daughters and a wife, and he had ulcerative colitis, and we did a pouch on him. And one day I'm at home with Amy, my wife, the gynecologist, who's never cut a ureter, and she goes, and suddenly I'm like, my phone rings, my cell phone rings, and my pager goes off. And we're literally on the couch, and she goes, somebody died, somebody coded. And it was him, 34 years old. And for nearly 2 weeks, I walked around believing that I killed this guy because of something that I did. And fortunately, not fortunately, but he had a rare heart condition that is in patients with UC, and that's what he had an arrhythmia and died. But you just get into this funk where you can't think straight. And my chair at the time, and this was the clinic, and we have a big department, he said to me, he goes, you need to take a break. He was Turkish. He goes, you need to take a break. I got you covered. Just relax, sit out. And it was the right thing to do because those things affect us. And we don't think about that. And the egos involved, not just in surgery, but in other specialties, are enormous. And they can lead to errors. So I agree with you. Okay, nobody film that stuff about the gynecologist, and don't tell my wife. All right, do you have a question? Yes. Back in the back. Way in the back.
That was a great presentation. Kimberly Dawn Wisdom from Henry Ford Health in Detroit. And my question is regarding with all that's going on related to DEI. I know the Joint Commission has taken a stance and has done some tremendous work. I'm just wondering how it's been impacted by the current environment.
In the words of a CEO of a major healthcare system out of Charlotte, he said, we're not going to back away from our values and what we think is important. We may be emphasizing things that are, we haven't emphasized in the past and de-emphasize some things we've talked about in the past, but we're not going to walk away from what we do. And that's kind of the position. And I think that, you know, it's knitting the fine line between that. I think that at the end of the day, you know, we all have a responsibility to kind of think about what's right. And, you know, that's kind of our perspective. So, and I think, and I would add, this is where I should clearly shut up, but I would add that I think that that's generally the position that the most healthcare organizations that we've talked to are taking, right? It's like we have a day job, we know what we need to focus on, we're going to focus on it. And some things, the terminology has changed, and that's okay. So, but you know, it's core values. Any other questions? That's the hardest question I'm going to get tonight. So anything else is easier. Well, look, I really meant what I said about this organization. You have a tremendous opportunity to network. And I would tell you that just in my personal experience, having been here and met companies that we have subsequently partnered with when I was in my previous organization, it's an opportunity to learn, and so take advantage of that. And if for no other reason, learn about other people's experiences and backgrounds, because at the end of the day, we all are in this unique ecosystem, and it's hard, and we can learn from each other and make what we do better. So again, thank you very much, and enjoy the rest of the conference.
Thank you so much, Jim. That was really amazing. Before our dinner concludes, I did want to mention that the night is still young. So we're going to continue the evening with some cocktails at the lobby bar right around the corner. And we hope to see you all there. Who's ready for a cocktail? Woo! Let's go. Okay, I'll see you there. And then tomorrow, breakfast at 7:30. You don't want to miss the breakfast keynote panel. It's going to be a women's panel at 8 a.m., so come and join us. Designing for Dignity, Building a New Model for Women's and Reproductive Health at 8 a.m., moderated by Monique Respand, VP of Imaging and Oncology at Class Research. So everyone, enjoy your evening.